She also has extensive teaching experience and currently covers the position of assistant professorship in Hamad bin Khalifa University, Qatar, and also Qatar University. She is leading the laboratory of precision nutrition, where she interests to characterize underlying the role of food and nutrition in pediatric non-communicable disease, also the development and management of pregnancy complications. Her projects focus on gut microbiota and epigenetic mechanisms using the most advanced technologies available in Sidra medicine. So she's going to present us the gut microbiota. Annalisa, the floor is yours.
Thank you so much. Thank you so much, Dr. Erdener, for the kind introduction, and both you and Dr. Funda for the invitation. It's an honor to be here, I mean, online, virtually with all of you today. And thank you for giving me the opportunity to talk about the gut microbiota, and then, I will gonna also give you a brief overview of what we do here at Sidra Medicine. So, I prepared this presentation starting from the basic, from the general information definition. So I'm going to give you the definition of human microbiota, focusing on particularly on bacterial microbiota, and then discussing the role of diet. As you heard, I mean, from my background, I'm a nutritionist, so I'm mainly interested on the effect of diet on the gut microbiota. And what we know so far, the approaches to modulate the microbiota. And then I'll give you, as I mentioned, an example of one of our research projects in Qatar about type 1 diabetes. So let's get started. What is the human microbiota? By definition, it's the collection of bacteria, archaea, and eukaryotes colonizing the human body. So, and this is really impressive. I put here these nice slides with some numbers about the microbiota. We are talking about 10 to 100 trillion of microbial cells that we host on our body, which means that it's, with the more than 10,000 different type of species. And this turns out that we have basically, we are more microbes than human cells, with even a big amount of genes, microbial genes, than human genes. Here you see the proportion is 100 to 1, which is impressive. Our human genome, it's about 20,000 known genes. The microbial genome is more than 3 million. So we can easily say that we are more bacteria than human, but this has to be, you have to think about it as a beneficial thing, as something very good. And nowadays, basically, 90% of any of the known disease can be, linked to the health on our gut microbiota, not only the gut. Because now, let me specify. I will focus specifically today on the gut microbiota, but it's not the only microbiota that we have in our body. We have microbes across all the GI tract, mouth, esophagus, stomach, gallbladder, liver, pancreas, and also is not pictured here in this slide, but we have microbes in, skin microbiota, vaginal microbiota, and many new microbiota are discovered every day, like breast milk microbiota. You heard about it a few weeks ago from my colleagues. And then placenta microbiota, and I can easily say that every part of our body has a microbiota. But the biggest one is the gut microbiota, which is covering 95% of our body microbiota, and is the one we're going to focus more on it today. So what we know about its function and its role in health and disease. So here again, I took this nice picture from a review which shows all the function of microbiota in healthy condition, here in green on the right side of the picture of the slide. So what is the role of microbiota? First of all, to reduce infection, so the even microbial infection. Then it's very important in controlling a lot of metabolic pathways like insulin sensitivity, inflammation, lipid metabolism, kidney toxin, antioxidant capacity, and all of this. It does this. It acts on all this function through a specific. Let me see if I can. Sorry, activate my laser point. Okay. I hope you see. So it does all this function through a specific metabolites like this one showed here as CSFA, which is short chain fatty acid. And what is controlling the gut or influencing the gut microbiota? You see here two major factors mentioned here in this dashed arrows: diet, especially fibers, and probiotic intake. I will give you an exact definition of probiotic in a minute. So this is, we call it eubiosis. I put it here again, this definition. So the healthy condition of microbiota. But what happens when this microbiota, these microbes get unbalanced? So we are in a dysbiosis condition. This is actually cause a lot of issue with many of this function. So it, of course, can increase risk of diarrhea, insulin resistant inflammation, increase many non-communicable disorders like CVD, diabetes, of course, increasing some of these negative or non-beneficial metabolites like the lipopolysaccharide and the TMO, and reduce the good one like short-chain fatty acid. So this is happening in a disease setting. And again, as I mentioned before, most of the known diseases nowadays, especially the non-communicable disorders, have an dysbiosis in the gut microbiome. What are the causes here? Again, diet. And I want to highlight the intake of fat, sugar, and excessive proteins. I'm going to give you more details in a minute. And also, of course, the use of drugs. Here it's mentioned just the proton pump and antibiotics, but I can tell you that now we know that many, many drugs affect the composition of our gut microbiota. Now, there are many factors that affect it. And again, I put these nice slides from a review. Here you have all the references if you want to go and dig deeper. That cause the imbalance of the gut microbiota. I mentioned the diet, I mentioned medications, but also other factors affecting it, as the circadian rhythm, the physical activity, weather conditions, sleeping patterns, and the geographic location, and also the socioeconomic factors that, of course, affect many of these factors, as we know. But I will focus mainly on diet because, as I mentioned, this is of my interest, and because this is one of the factors that we can easily, if you allow me, control to modify our microbiota. Oh, seems that I'm not able to move my slides anymore now. What happened? Can you see my slides moving?
No, we don't see.
Why all of a sudden get frozen? What happened?
Yeah, we can see your last slide.
Yeah, the lifestyle, right? You're still there, but I'm still there too. It seems that is not moving even on my computer. What's happening? Okay, I find a way. Okay, good. So do you see now the new slide?
Yes, excellent. Okay. Thank you.
So as I mentioned, I want to focus mostly on diet because of my personal interest, but also because is now microbiota is considered really important in terms of nutrition. Here I put the definition of precision nutrition from Harvard School of Public Health, which states that under the umbrella of precision medicine, precision nutrition assumes that each person may have a different response to specific food and nutrient. So the best diet for someone would gonna be is the same for someone else. And under the umbrella of precision nutrition, we have to include the gut microbiota, again, as we defined, which is unique to each individual. And our diet can determine which type of bacteria live in our body, but the opposite is true. So the type of bacteria that we house in our body might determine the way we break down, we metabolize the food that we eat. And we also tried with my team to summarize this concept together with other interaction of genetic background, epigenetic, and so on, because this is basically what we are trying to do, applied to different type of research. So let me give you a few examples of what I mean when I say diet affect microbiota. Here, I use this slides from a quite old review, but it's still very, clear and touch the most important points. So we know that diet, we can have different type of diet, different dietary pattern, we used to say. Here, I mentioned the most famous one, like the Western diet, which everybody knows is not healthy dietary habits, and is known to be a risk factor for diabetes, cardiovascular disease, cause obesity, inflammation, and so on. But also the Western diet is causing dysbiosis. So reduce the amount of the beneficial bacteria, and here few are listed, and increase the amount of the pathogenic bacteria. And opposite, of course, it happens when we have a more healthy diet style, and here the example of the Mediterranean diet. They still have dietary patterns that are controversial. Here, the review discussed the gluten-free diet. Everybody knows the importance of having a gluten-free diet for celiac patients. No point on that. But what happened to the gut microbiota when we eat a gluten-free diet? It seems that this causes some dysbiosis, very similar to the Western diet. Now, we cannot say that this can cause a non-communicable disorder, but we have to be very careful. And to avoid the gluten-free diet, one is not, needed. And why? I mean, it's very simple. If you remember, I said you that diet, and particularly fibers, are very important for the gut microbiota. And gluten as well, as fiber is basically, we find it mostly in carbs, in grains. So that's why the two things probably go together. Also, proteins and fats, I mentioned, they are not healthy for microbiota, but we have to be careful. We need to understand that there is different type of proteins, different type of fats. So when we say unhealthy proteins, we talk more about animal proteins, particularly processed food and, fat meats, which again cause dysbiosis and is associated with non-communicable disorders. Whether opposite, we can say for protein, plants as protein that are beneficial for the gut microbiome. And same for the fats. Good fats, like unsaturated fats, are good for microbiota. Saturated fats are not healthy. So diet is definitively, I hope I convinced you, we can control the health of our gut microbiota through diet. But because microbiota is becoming more and more important, as I mentioned, in many diseases, nowadays also there is a lot of effort in developing a therapeutic approach to treat dysbiosis, okay, to control the microbiota composition. And here I listed the major ones, and I'll put you the official definition of those. So first of all, the prebiotics, which are basically the good bacteria, because are live microorganisms that are intended to have health benefits when consumed or applied to the body. So it's very similar to what we have in our body when we are in a healthy condition. The good bacteria, probiotics. Prebiotics are the non-digestible food ingredients that beneficially affect the host by selecting the good bacteria. Okay, so those are mostly diet components, so the fiber I mentioned to you before, another non-digestible food that can improve the microbiota. And then symbiotic are the mix, the combination of the two, whether postbiotic, as related or resulting from living organisms, and the prefix post means after. So afterlife, non-living organism. Is basically the same of probiotic, but those organisms are not alive anymore, or we use just some part of this organism. And then we have adsorbent, which is toxic compound. We use it to capture toxic compound and overdose the drug. And very simple example is the activate charcoal, which has an impact on the gut microbiota. And the last one I want just to mention, because I'm not an expert on it, is the fecal transplant material, fecal microbiota transplant. It's the administration of solution of fecal matter from a donor to a recipient, to the intestine tract of a recipient. It's a transplant. So basically, fecal material of an healthy subject is given to a patient. And it's starting to be approved in many disease conditions. I can mention Helicobacter pylori infection, and now recently is close to be approved for IBD treatment. And there are many studies that are, many studies are looking at the beneficial effect of the FTM. But let's go back to food, which is my, my love. All this definition I give you, probiotics, prebiotics, symbiotics, yes, we can get them in pills, and this is what most of the pharma companies are working on, which is probably the ideal solution when you target a disease population or, patients, because then you can well control, you can select your precise bacteria. But we can also find all of these probiotics and prebiotics in food. And here I want just to give you a few examples, to get familiar with this. So where we find the probiotics like Lactobacillus, Bifidobacterium, Streptococcus, very simple, in fermented food like yogurt, kefir, Gouda, kombucha, kimchi, and many of the traditional food that we have in almost, I would say, the traditional cuisine. Prebiotics, also those one, here few names like fructan, fructooligosaccharides, galactooligosaccharides, resistant starch pectin. All of those are naturally present in foods, of course, mostly vegetable and fruits. And the last is the symbiotic, which is the combination of the two, as I mentioned to you. And here also, we have to, it's not random, but usually we combine the two in a way that they are more efficient, and the way it works gives us the results that we are expecting. And here a few examples like yogurt or kefir with honey. We probably eat since our childhood this, and we don't know that this is a symbiotic and is beneficial for our health. Also kefir and kachagam or beans and pickles, and I can, you can read all the list, and this is only a selection. So I hope with all of this, I give you a nice overview of the role of microbiota, its function, how we can control it, in the difference in between health and disease. And I'll try to, in the last part, I'll give you an example of how we study it in a disease condition, in a pediatric disease condition in this case. So this is Sidra Medicine building. You see in the photo, which is beautiful hospital where me and Erdener are lucky to work in. And in particularly my lab, the Precision Nutrition Lab, as you heard from him, we are interested to look at the role of diet in the development of non-communicable disorders. Again, diabetes, obesity, CVD, and others. And we do this mainly focusing on the role of diet, on the gut microbiota, and on the modification of some genes. So I will give you the example of type 1 diabetes. Why we are studying type 1 diabetes in Qatar, you may know, or you may share with us this drama, but this is one of the most, the worst health condition that we have in our country, and we rank very high worldwide for incidence of type 1 diabetes. We have like 20% versus 9% worldwide. So it's really, it urges us to address and tackle this disease. And the way I do, again, is from the angle of microbiota and diet. You will wonder why. Everybody knows that type 1 diabetes is an autoimmune disorder with a genetic, predisposition, very genetic determinants. It's all true, definitively. But as depicted in this review, genetics cannot explain everything. And in this review, these authors were very good in explaining why it's worth to look at the gut microbiome. Here you can see in the picture, basically, it's trying to explain the link between, okay, so we have the food and the microbes, metabolites. This is the gut, right? The lumen gut, the gut lumen, and the epithelium and the lamina propria, where we have most of the immune cells that are directly in touch with the epithelium and sometimes even with the lumen. So they can feel, they can, they feel what is in our gut. And this is affecting their function, their immune function, the activation, and the balance of our microbiota is reflected in the immunity balance. So between telerogenic condition and inflammation. And this is what they then reflected at the level of the pancreas and the beta cells, increasing what is the inflammatory condition and so exacerbating the cause of type 1 diabetes. So microbes probably are not a trigger of T1D, but are modifiers. And being diet a major controller of microbiota is definitively worth to study. So we do it. What we do. This is our study that we are running at Sidra Medicine on our patients. And the title is the triple interaction diet microbiome epigenome in pediatric type 1 diabetes. So we have actually now a bigger cohort. I mean, we are aiming for a bigger, what is depicted here. There was the original study design. But we recruit, of course, type 1 diabetic kids. We also have a special subgroup of those which are type 1 obese, which is very rare, but not so rare in Qatar. And of course, we compare those two groups with healthy controls and with obese, they are not diabetic. And we use a very, multidisciplinary or multi-omics, anyway, very deep phenotyping. We do a very deep phenotyping of our patients. Of course, we have all the medical history and medical records. We do dietary assessment with collecting their dietary habits, their anthropometric composition. We use some blood tests like lipids, of course, glycemic, but also liver and thyroid profiles to better characterize the metabolic condition of this patient. And then we collect samples for those, more advanced technologies that luckily we have at Sidra Medicine. And so you have here in the middle of the slides, the list of all the omics that we use for this project. The first two are around the microbiome. So we use next generation sequencing, as well as metabolites analysis with gas chromatography, mass spectrometry. And then I'm not going to discuss with you today, but we also do some analysis on the gene expression and DNA methylation with the final aim to integrate everything in a kind of artificial intelligence, if you allow me anyway, machine learning approach. So we started this study few years ago, 2018, and we already have some published results from a pilot phase of this study, which I would like to share with you today. This is only on the T1D subgroup. If you so from the 4 that I mentioned to you, we analyzed in this pilot only the T1D, pure T1D. So it was a pilot of 28 subjects in the age average of 10 years old. We have both girls and boys, but mostly boys. We analyzed their dietary intake and, of course, classified them as per ethnicity. So comparing the local, the Qatari versus expat, which we have, as you see, 50%, equal distribution. And in particular, in this paper, we look at the glycemic control in our type 1 diabetic patients. And we used HbA1c as biomarker of their diabetes. So if these kids have a HbA1c above 7.5, clinically, the doctor defined them as not well controlled. And well controlled when as lower 7.5. So we classified our kids as following this criteria. And we also, we have many other things that I'm not going to mention, but you can look at the whole paper if you are interested. And for sake of time, I'm going to focus only on a few things. Which are those? 2 results I want to share with you. Diet intake of these kids and the gut microbiota composition. First, the diet. So here I listed, in this table, all the significant nutrients. So, thanks to a software, we are able to compute the single nutrients intake from the dietary record from the interview that we have from the patients. So I'm able to say how many kilocalories, fat, proteins, vitamins, going down to the micronutrients. And these are the main differences between well and not well controlled patients. But I want to drag your attention on these 2 where I put the green arrows. Fibers and cholesterol. So these kids, they have lower intake of fibers and higher intake of cholesterol. So the kids, they have high level of HbA1c. And if you remember, I mentioned that these 2 factors are very important to control the gut microbiota. Fiber are beneficial and fats, the animal fats as cholesterol, are not beneficial. The gut microbiota composition. Now, I'm not going to explain the technicality behind it, but I can tell you that usually when we measure the microbiota through sequencing their genes, we are able to classify them, to give them names. And you see here in this pyramids, we are able to classify them from a less specific, which is the phyla level, to a more specific level, which is genus and species. And here, in this bar graph, which is a discriminant analysis, we are able to compare our patients, here the HbA1c below and above 7.5, and see the difference in their microbiota composition. I highlighted here the major 2 differences. So these 2 bacteria, Ruminococcus and Akkermansia, are across to all its orders, to the specific down to the phyla of Vercomicrobia, so it's the whole phyla, but particularly the Akkermansia, are abundant and present only in the kids that have worse glycemic control. And if we include diet here, the dietary intake, we see the only kids which have a more traditional diet, which is Arabic diet, conserve, are able to show the same microbial pattern. Okay, whether even if they have higher level of HbA1c but you have different diet, we don't see the same microbes here. So again, diet is very important to control microbes. But not only, I want to drag your attention here on the nationality. We have, I said, we compare the Qataris versus the rest. And once again, this specific profile, microbial profile, it's unique of the Qatari population. So ethnicity is also important. So what we could conclude from this preliminary finding study, yes, that we identified Akkermansia as elevated, a biomarker of poor glycemic control, but particularly in the Qatari pediatric T1D patients that consume Arabic diet. So yes, definitively, it's a combination between genetic factors and dietary habits. So what we can, let me conclude, we give you some kind of, a suggestion. Now moving back to the clinic, what we can take from these results and how we can apply, in the treatment of our patients. This is just, we are still at the level of speculation, at the level of, preliminary data, but there are good signs that this could be, as a valid finding. So what we can do, two things. From one side, we can recommend the patients to improve their diet, and in particularly to increase the intake of fibers and to reduce the intake of cholesterol. And how? For example, for cholesterol, we should reduce the intake, of course, of fast food and sweets and eggs and desserts. And for fibers, we should increase the intake of all the vegetables and the legumes and grains. Now, also we include fruit and grains. And we know this is not really, we cannot recommend this recommendable for the diabetic kids. So we have to be sure because of the glycemic control. So the only recommendation we can give them from the vegetable sources, the plant sources food, is to improve in terms of legumes, nuts, seeds, and vegetables. The other recommendation that we can take it from here is that, yes, definitively we can introduce the use of probiotics and prebiotics. And in particularly here, we are very happy to see Akkermans as one of the, the results of our study, because we are not the only one have seen this data. And there are already some trials, both in T2D and T1D, here are summarized in this very recent paper, that are trying to supplement diabetic patients with Akkermans, and they have seen a lot of beneficial effect. So hopefully we can use a symbiotic approach with Akkermans together with the fibers to treat type 1 diabetes. This is, of course, it's a bit early to say. This is our hope and how we can move forward, but this is just an example, okay? So, and then with this, of course, I have to thank the team in my lab, that is the one who made all of this I showed to you. It's not only me, with the clinicians and the course and, a very great team that we have at Sidra Medicine. And of course, all the research team, which I belong to, that is the maternal and child research team that we work very well around these topics. And with this, I concluded, and I'm happy to take any question, and please contact me if you, want to discuss this further. Thanks for your attention.
Annalisa, thank you very much for your excellent question. I'm seeing only one question in the chat box. Sorry, two. The first one, are postbiotics and parabiotics the same? Is there any clinical advice for using these products?
All right, so postbiotics and probiotics, did you say?
Parabiotics, yeah.
Yeah, no, they're not, they're not the same by definition. As I mentioned, the postbiotics are the no live components or no live organisms. So are the ones that are inactivated, and are mostly, I can tell you, if you read most of the studies, are the product of the bacteria. So could be metabolites of the bacteria or just small component. Whether the probiotic is the actual bacteria. As I mentioned now, for example, the Akkermans is an example. Is the bacteria, the live bacteria, a live bacteria that we can take it as it is. Okay, so clinical advice at the moment, as I mentioned, it's still, there is not, there are some studies in, some disease, where you can advise the use of specific prebiotics, but there is still a lot of studies because we didn't reach yet the level of precision medicine or precision nutrition, if you want, allow me, where basically we know exactly what is the bacteria to give to that specific patients. I think I gave you enough proof that it's not only a matter of a disease, but where the people lives, the age, the socioeconomic conditions, so it has to be really personalized. And there is still a lot of work to do on that.
Thank you very much. The next question asked by Dr. Arzu. She thanks for your presentation, and she asked what the role of other microorganisms such as parasites and viruses for microbiome studies is.
Thank you. Very good question. I'm not the expert on that because, again, I mainly work on the bacterial microbiota, everything I showed you. But there is a lot of research on other microbiotas like the virum, like the fungi. Yes, there is. And it's getting more and more interest. And also these other components of the microbiota are relevant in diseases. And plus, there is an interaction between the two. I mean, among those, it's not the gut, the bacterial microbes, they live in their own world, and the virus, they interact each other, and they affect each other in the disease settings. Yeah, there is.
Thank you very much. Once more, thank you for your excellent talk. And let's move to the next speaker. Professor Funda, who has obtained her bachelor degree in Hacettepe University School of Medicine and her pediatric residence in İzmir and neonatology fellowship in Dokuz Eylul University. Her research fields include neonatal ventilation and postnatal growth of preterm infants. Professor Funda, stage is yours.
Thank you, Dr. Erdener, for your nice introduce. And also, I would like to thank Dr. Annalisa for introducing us and sharing her results, excellent research result. I also would like to thank both centers, both Dokuz Eylul University and Sidra Research Center for giving us this opportunity. As a clinician, today I wanted to talk about the impact of microbiota on newborn health diseases. My outlines will be the influencers of newborn microbiota, its effect on early diseases, and I will mention about some intervention in this critical time period. I don't want to mention about probiotics, prebiotics, and some other therapeutic elements, because this is a large area, and each day lots of paper has been published. So I want to narrow my area, mentioning with natural ways. As we all know that, and Dr. Annalisa shared with you, our microbiota grows with us. We don't know whether we are host or them, but the evolution of the microbiota from the intrauterine period to the adult stage is a long pathway, and there are different critical periods. As we assume today, maternal conditions such as gestational age, diet, body mass index, exposures, even stress affect the healthy microbiota of the mother, and especially the gut, vaginal, and oral microbiota of the mother affects the progress of pregnancy. And the main results of this any imbalance is preterm birth and consequence diseases. Also, we know this very well, the birth type affect the microbiota development, and the feeding type is also a key factor. Microbiota change during pregnancy, oral, gut, and vaginal microbiota shows some differences during pregnancy. We don't know why and how these changes occur, but we assume that this change occur for the requirement of the healthy pregnancy and a healthy fetus. So any disturbances in this process cause preterm birth and diseases. So, I want to mention about this concept, the concept of uterine colonization. In the recent years, there's a concept of placental microbiota. As you know, long years, we were knowing that the placenta and the intrauterine environment is sterile, but today there are lots of studies about this, and those studies claim to detect distinct placental microbiome. And the similarities between the microbiota of meconium, placenta, and amniotic fluid of healthy infants suggest a prenatal microbial antigen transfer, or maybe a common source of contamination. There are also opposite studies, and these studies found no evidence for a placental microbiome. So we need to further develop this hypothesis that if it's true, the effect of intrauterine environment is more than the postnatal period. Gestational age affects placental microbiota. And in this study, preterm and term infants' placentas were compared. And as you see in the figure, term infants have abundance of lactobacillus species, whether preterm infants, especially the ones suffered from chorioamnionitis, had oral-like flora and vaginal flora containing uroplasma, as you know well. So these differences cause preterm birth, imbalance of gut, vaginal, and oral cavity microbiota results in imbalance, inflammatory reactions, and maybe direct bacterial dissemination from the oral cavity. So all these factors may result in preterm birth. There are different factors affecting the term infants microbiota and preterm infants microbiota also. And when we look at the factors shaping term infants, this is a very large cohort study including about 1,000 term infants. And according to the results, breast milk is the key factor affecting the microbiota in metagenomic level and also functional level. And this effect continues till 18 months. And in the early periods, maternal preeclampsia and birth mode were also found to be important influencers. When we look at the preterm infants, there are similar results, but as you guessed that preterm infants face with neonatal intensive care unit, so they have different influencers. As you see in this figure, this is also a very large cohort study. Antibiotics, breast milk fortifier, and of course probiotics have impact on the development of preterm infants. In the study, all of these infants were healthy preterm infants, and results show that breast milk microbiota of preterm infants have various co-founders like mother's own milk, breast milk falsifier, antibiotics, and probiotics also. This is a systematic review including 14 studies, and they evaluated the factors influencing the breast milk microbiota and maternal factors affect the breast milk microbiota and the components also, and there is an interaction with breast milk microbiota and infants, intestinal, fecal, and oral microbiota. In this review, one of these studies belonged to our unit. It was my thesis during the fellowship period, nearly 10 years ago. Here we wanted to evaluate the effect of breast milk microbiota on breast milk jaundice. And for this reason, we evaluated the healthy term infants and mothers pair and collected their stool and breast milk samples. The results show that Bifidobacterium bifidum were abundant in the breast milk and fecal samples in the control group rather than jaundice group. And there was a significant correlation between the milk and fecal concentrations of Bifidobacterium bifidum. Also, according to our hypothesis, we suggested that Bifidobacterium concentrations in breast milk show a negative correlation with serum bilirubin level. There are lots of studies after this, and this hypothesis is confirmed with the following ones. So, preterm infants, especially different, and consequences of dysbiosis show its impact on this vulnerable population. I don't want to mention too much about gut microbiota because it's the topic on the first one. But I want to show you one meta-analysis about this topic. In this meta-analysis, 14 studies included infants who suffered from necrotizing enterocolitis, or the control groups were compared. The results show that, especially beginning from the 27th gestational age, abundance of Proteobacteria and decreased abundances of Firmicutes and Bacteroides types shown in the necrotizing enterocolitis group, and these results show that this disturbed microbiota may precede the diagnosis of necrotizing enterocolitis. So microbiome-based biomarkers can accurately detect a risk of disease. This is a question of the recent research, and I found a meta-analysis about this issue. They collected 25 studies. Some of them also evaluated the metabolome, but results were conflicting and heterogeneous because of the definition of NIC and the technology used in the studies. But these studies, all of these studies are encouraging. Since this is a highly popular area, I found another research indicating the opposite of this, especially in the preterm population. This study included preterm infants under 32 weeks, and they were followed from the birth till the 2 months. Their stool samples were collected in different time points. and their metabolome also detected. And during this follow-up period, infants were divided into different groups. This cohort, some of these cohorts did not show any sepsis or enterocolitis, but nearly 1/3 of this population showed necrotizing enterocolitis or sepsis. The results were not favorable for the others, because when you see here, the microbiome composition of these infants controlled septic or necrotizing enterocolitis did not mean too much things, and the results were not significant. However, when they follow the infant preciously, they show that the microbiota of infants and their metabolomes show a trajectory, and this trajectory is unique to each infant. So rather than finding microbial signature of the disease like necrotizing enterocolitis, and this may reflect the other diseases of preterm babies like BPD, brain injury, preterm infant microbiome and metabolome were personalized. And this study, I think, emphasized that a personalized view will be important. All we know that there is a gut, brain, and microbiota signaling. And in this axis provides neural, hormonal, and immunological signaling between the gut and brain, with direct and indirect ways, including the vagal nerve circulation, and microbial metabolites also directly pass through epithelial cells, affect the brain blood barrier. Also, they cause different reactions by binding receptors. As well as microbes can play a direct role in the production of different neurotransmitters, such as serotonin, gamma-aminobutyric acid, and these metabolites play a role in brain development also, and also gut functioning. Role of microbiota in neonatal lung injury. I think this is not old for the gut microbiome. But today there are lots of studies implicating that. I think it's important to ascertain whether an airway microbiota exists at birth and whether it's associated with subsequent lung diseases. This study is initiated, and in this cohort of infants, full-term infants and extremely low birth weight infants were compared. Their tracheal lavage fluid was studied and compared with the infants' microbiota at 36 gestation postmenstrual week who developed BPD. So there were 3 groups, and the results show that, interestingly, the relative abundance of commonly encountered bacteria were similar between the full-term and extremely preterm birth weight infants. These were similar, but different from the infants who suffered from BPD. Also, infants with BPD had increased proteobacteria types and decreased Firmicutes and Fusobacteria. So, these results implicated that just after birth, an airway microbiota exists, and it affects the development of BPD. Also, there is another important thing in this study. There were no differences according to the birth type, whether the infant delivered by vaginal way or C-section, their airborne microbiome were similar. So this is also indicated potentially intrauterine development of lung microbiome. In this study also, Just after the birth, they divided infants to groups, infants who developed BPD and who did not develop. Infants who did not develop BPD defined as BPD resistant group, and their initial microbiota show an abundance of lactobacillus species compared to infants who predisposed BPD. So these results may implicate that initial airway microbiota is important. It's important for a diagnosis, for a biomarker, or also treatment options. There are other studies indicating the airway microbiota, and all of these studies were parallel. The airway have a diverse microbiome even at birth, and infants BPD had characteristic findings of dysbiosis. So there is a window of opportunity for microbiome modulation because we have critical time periods during the pregnancy, and we may do something besides the therapeutic ways to protect microbiota. I want to mention about prevention, modulation, and replacement or restoration ways. So as a neonatologist, I want to start from the preventative strategies in the NICU. This is a large cohort study. It's a part of EpiPage study in French. And in this study, they evaluated 8 different practices and the impact of these practices to the macrobiological analysis and also neural development at 2 years of age. So this long-term study, infant stools studied at 4th week after birth, and the composition of microbiota divided to 5 clusters here. The cluster 3 represents the healthy microbiota of term infants. So results show that individual practices affect dysbiotic chains, and no intubation, extubation early in the first day were positive mean of prevention from dysbiosis. Sedation during first week was unfavorable. Low volume of enteral nutrition, as you all know, unfavorable. And early skin-to-skin practice in the first week, this is important, in the first week, and direct breastfeeding from the mother is very important to develop healthy microbiota resembling the term infants. And also the results show that certain classes are related with that or disturbed long-term neurological results. I want to mention about oral care with breast milk, although there are not enough evidences, but one study from France, Daniel Deluca and equipe conducted a study. Infants who oral care performed with breast milk, formula, or sterile water were compared, and the results shown that in extremely preterm infants, oral care with breast milk caused a significant increase in local immune defenses like lactoferrin and secretory immunoglobulin A. Also, they didn't evaluate microbiome. This study is encouraging about breast milk cleansing of the oral cavity. Hyperoxia is another important factor because it is it affects the development of lots of diseases in preterm period, but a disturbed microbiota also affects the disturbed microbiota also affected by hyperoxia exposure. In adult studies, it has been shown that after hyperoxia exposure, oxygen tolerant microorganisms were positive, like Staphylococcus aureus, and decreased abundances of facultative anaerobe types. And in the experimental studies, hyperoxia caused dysbiosis. So lung dysbiosis also predicts lung injury in hyperoxic mice. There are lots of studies indicating that hyperoxia is a confounder of influenza, and it affects developing of healthy microbiota, both gut and the lung microbiota. So I don't have too much time, but this is interesting. When we look at the transfer studies, I've shown this picture from news in the BBC, and it's asking whether is it okay to suck on baby's pacifier. And some research shows that parents who suck their pacifiers to clean it may be passing healthy microbes that boost their child's immune system. This sounds weird, but in Pediatrics, almost 10 years ago, the researchers showed that infants whose parents clean their pacifier by sucking them, these children show less incidence of eczema and asthma at 18 months of age. So the results are interesting and need to be developed, because there are lots of opposite ideas about it. And transfer of vaginal bacteria also important, and this is also popular topic today. Vaginal seeding is a concept of restoration of microbial flora with microbiota derived from healthy mother's vagina at birth to mimic vaginal delivery transfer. As you see in the figure, babies delivered via sexio being swept with vaginal content of mothers, just beginning from the mouth, face, and the corp. And these infants and mothers were followed, and their skin, oral, and anal microbiota were studied, and results show that transferred infants, inoculated infants, show a similar bacterial content to vaginal birth infants, and also if you see the representative bacterial taxa during the first month, lactobacillus abundance were relatively higher in these groups of infants who had been transferred. So it seems encouraging. This is a proof of a principle of work that transfer of vaginal bacteria to newborn may be feasible, but some health outcomes of this procedure needed to be determined. There are other studies after this. I will not mention, but the others also hopeful. But since this is a very popular topic, and the families, the parents wants to use this application, the American College of Obstetricians published a commentary about this issue, and they do not recommend or encourage vaginal seeding outside of the context of a research protocol because of the hesitancy of unhealthy vaginal microbiota, and it needs to be confirmed further. And also Danish society published a commentary and they strongly against vaginal seeding, especially in preterm infants whose mother have group B streptococcal prophylaxis, and in certain conditions that vaginal microbiota has different kind of infections. So today, this is not a suggestible option. It needs to be developed further. Not only the vaginal microbiota transfer, but also fecal microbiota transfer from mother has been evaluated. And in this clinical study, including few infants, show that infants who transferred maternal fecal sample and infants who did not transfer sample were totally different in terms of microbial composition. And infants who transferred fecal sample immediately after birth were more close to vaginally delivered infants. So this proof of concept demonstrates that the intestinal microbiota of C-section born infants can be restored postnatally, postnatally by maternal fecal transplantation. However, this should only be done after careful clinical and microbiological screening. It's not recommendable right now. And also oral transfer of vaginal microbiota also studied, but it wasn't effective. So in conclusion, we need to create a bundle for routine care of newborn infants, especially early skin-to-skin contact, early breastfeeding, especially breastfeeding from the mother's own breast is more effective than breastfeeding from the bottle. Reduced use of sedation, early extubation are important practices, and also avoiding hyporexia is working everywhere. Microbiota transplantation studies continue. We need longer-term studies, and also we need to understand the trajectory of microbial signature in diseases and in personalized way. I want to thank you for listening to me. Thank you very much, and take care of your microbiome.
Thank you very much, Funda. I'm looking at chat box. No questions so far. Probably I may ask you about the link between the placental microbiome and neonatal outcome.
Placental microbiome and neonatal outcome. If it's a true concept, placental microbiota and the different metabolites coming from this, especially I think the most important consequence is preterm birth. So others are coming each after. So the first hit is preterm birth. And there are studies for mothers and of course healthy diet, reducing stress, all of these factors affect maternal microbiota, and also probiotic replacement therapies for avoiding preterm birth. But today there is no such a way for avoiding this using these agents. And placental microbiota may affect, if it's true, it affects the preterm delivery. Also, it affects the microbiota of airway. So it has, their effects are multiple. I think.
And there are many thanks in the chat box to each speakers, and also question. Dr. Doğan, what is the effect of prolonged delivery on the newborn microbiota?
Thank you. Doğan is our student. He is our intern, and I think this is a good question. I cannot answer this with using evidence, but prolonged delivery, this is not a way that we like for the further outcomes, like perinatal asphyxia, and we don't know whether contacting vaginal microbiota 1 hour or more affects the microbial shaping of these infants. But I like this question. I think it's worth to look at after the presentation.
Thank you very much. Before closing the session, I would like to thank both speakers for their excellent talks, and also our Dean, Professor Nur Olgun, and our Vice Dean, Professor Aydan, for everything, and for organizing these webinars. And before closing, I want to wish you a happy Christmas and Happy New Year. Thank you for your participations. Bye-bye.
Thank you.
Thank you. Thank you, everybody. Merry Christmas.
Happy New Year.